Good evening, everyone. I hope everyone is prepared for our um, very interesting session. Uh, just before we start off, we just have a couple house rules that we need to go through. So I think we should go through the house rules right now. Thanks for joining us for today's webinar on coronavirus and your indoor air quality, preparing for a pandemic. Today's webinar is going to be sponsored by our sponsors on the ASHRAE Caricom end of things. We must thank ESCO, Switch On, IAQ Solutions Incorporated, Temtech Limited, Caribbean HVAC, Walsh Morris and Associates, Stages Consulting Engineers Limited, and AV Concepts TT. Before I introduce one of our two speakers, I would like to cover a few housekeeping topics. Today's webinar is recorded. We will be able to share the link with you after the event is completed. We welcome you to revisit the content yourself and share it with your colleagues. We also invite your comments and questions. Please look at the question and answer chat box on your screen. If you have a question for the speakers at any point in time, just type it in there and I will either pose it to the speakers at that time or hold it for discussion portion at the end of each session. Today's presenters will be Dr. Stephen Ramroop going firstly. Dr. Stephen Ramroop is an orthopedic and trauma surgeon practicing for over 29 years. He has worked as a specialist medical officer at the San Fernando General Hospital and has served as the head of care of the emergency department and medical chief of staff at this acute care hospital. He was appointed as the medical operations manager, for the FIFA Under-17 World Cup tournament and the ICC World Cup cricket tournament. He served in this position in the Fifth Summit of the America and served as the medical liaison officer for the White House medical team and received the Meritorious Award from the United States President Barack Obama, who attended the summit for his external engagement. He also served in this position for the Commonwealth Health of Government meeting as well. Dr. Ramroop was appointed Chief Executive Officer of the Office of Disaster Preparedness and Management, ODPM, of the Ministry of National Security in 2011 and served for 6 years. He was instrumental in implementing disaster risk reduction policies and protocols at all levels in Trinidad and Tobago and served on the CDEMA level as one of the directors in his capacity as National Disaster Coordinator and was able to influence with the assistance and development of a number of regional and international policies and DRR strategies, model legislation and DRR toolkits, etc. He served as the intergovernment expert in the UN Working Group to develop the indicators for the monitoring and evaluation of disaster risk reduction program and policies in the UN member states in accordance with the UN DRR Sendai Strategy 2015 to 2030. Dr. Ramroop has been developing a certificate course in DRR, crisis management and communication, business continuity in disaster, flood management, and healthcare management, and facilitating them at the University of Trinidad and Tobago and the University of the West Indies. Arthur Lockjack School of Business. He also provides consultancy for DRR, healthcare management, and emergency management, and as an individual consultant, he is the lead consultant of Disaster Risk Management and Healthcare Consultancy Limited and is the interim president of the Trinidad and Tobago Association of Healthcare Quality. Dr. Ramroop has been a Rotarian for the Rotary Club of San Fernando South and has served at all levels as Director, Treasurer, Secretary, President, Assistant Governor, and as District Governor for the Caribbean clubs from Antigua in the north to French Guiana in the east, to Aruba, Bonaire, Curacao in the west in 2012 to 2013, and now serves as the District Disaster Chair and coordinated over $150,000 cash donations for Bahamas recently. He is also the Vice Chair of the Caribbean Partnership for Zones 33 and 34 of Rotary International. Let us welcome Dr. Stephen Ramroop.
Hello.
Hi. Yes, Dr. Ramroop, we hear you.
Right. Now, let me see technology. Can you see me?
Not yet.
Not yet. Right. So we're trying with the webcam. I know you're hearing me. Unfortunately, I'm not seeing the icon again for the webcam. Maybe something on my end.
Hold on a second. Let me just give me 1 second.
So we were pretty good. Right. Share my webcam. Right. Can you see me? Yes.
Not yet.
Okay. I'm seeing share my webcam.
Okay, try mine and let's see if we get yours. Okay, so mine's is working. Cutting you now, Dr. Ramroop.
Can you see me? Yes?
Yes. Perfect.
Beautiful. I'm not seeing me, so you see me. That is very, very interesting. But thank you very much for having me on. And I'm here to talk a little bit about the current COVID-19 virus in terms of a sort of medical perspective. And if at any time you guys have any questions out there, I'll be happy to answer them because it probably will be a more focused presentation. Quite a lot of information has been circulated on the international web. These days, it is very easy to get information, but information and knowledge are two different words, and we have to be very careful because sometimes, although things are written, it's very hard sometimes to understand them in the context of an easy explanation. So today, the intent is to really not get into too much details into the pathophysiological mechanisms of the virus, except to say that it, as you know, started in China. And basically, recent research has shown that the virus seems to have mutated naturally. This is putting a lot of these conspiracy theories to rest because they have shown that apparently the molecule, the virus itself, the spike or the spiking proteins, which you're seeing on the actual corona, means a crown. And as you look at there are two types of proteins on the virus. And the one which is called the spiking protein, the one that is kind of shooting up or the size of the crown, that has a particular affinity for the angiotensin inhibitor enzyme in the cell of the humans. So apparently the virus over many years it looked very similar in the bats, and then there was another animal which apparently it actually evolved and it was able somehow to get into man. And then right now the virus is being spread from man to man. And this is where the problem is actually. So when it started in China, obviously people were noticing it started around November the 17th. The first case was identified in Wuhan. And it's very interesting to know that on January the 19th, the first case was noted in the United States of America. So which means that over the course of time, a lot of things was happening in China. And the world was looking at the virus. We were looking at it on the news. And many persons at that time were saying, oh, they will never reach us. And there was good, we all, most of us would have said, hey, something is happening, but it wouldn't come to us. Because there were a lot of viruses like SARS and MERS, H1N1. So there were viruses in our recent past, and basically we didn't seem to be getting it too much. I know many persons died. In fact, one of a close Rotarian friend of mine, who was a district governor, a past district governor, she had died due to the H1N1 virus. That was the cause of the respiratory problems that she had. So when we looked at that, we looked at the spread, we realized that it was going man to man. The problem was that over the past few weeks, there's been a lot of research that has started. In fact, the New England Journal of Medicine, a group of persons there actually started completed a little study, which still has to be verified by other experts in terms of research. They have to verify it, they have to repeat it, as you know. And obviously it hasn't gone through the whole peer review analysis as yet. But it did indicate that the virus stays a longer time in stainless steel compared to cardboard. When we looked at it in terms of days compared to hours, and therefore now we are using in the scientific community from 0 to 9 days, that this secretions from a person who's shedding the virus can actually remain on fomites. And fomites could be doorknobs, door handles, flushing devices on many toilets, car door handles, money even, right? So quite a lot of fomites, and basically we have to be very careful about what they mean by airborne spread. Recently, a team of researchers have found that the airborne component is not as bad as we thought, except that it remains in the vicinity of the person with the disease. But in terms of it staying there for a very long period, it's not. What actually goes across when the person coughs is that these fine, very tiny little droplets or secretions are able to get across to the potential victim, as it were. And therefore, that is why we recommend that persons with the disease, with the virus, with the symptoms, and the symptoms usually, and that is the problem with it. It's a virus. It's like a common cold. There are a few little differences in terms of coronaviruses, or what we call the SARS coronavirus, in that it does cause a high fever. It does cause a dry cough sometimes without too much mucus. But basically, a lot of the symptoms are feeling tired, listless, vomiting, sometimes trouble breathing, which is the most important one later on. And of course, because of the possibility of the angiotensin enzyme, the angiotensin 2, it seems to have an affinity for older persons. Although recently we are seeing that younger persons are also getting affected. So this is very interesting. Obviously, persons who are with low immune responses, people, diabetics, people who have cancer, being treated for cancer, who are on autoimmune drugs, persons with leukemia. I know that there was a young man recently who passed because of leukemia. So leukemia is a complicated what we call comorbidities. In other words, then if you're healthy, the chances are that you might get a low-grade virus if you have a good immune system. You're well nourished, you're well hydrated, and you're fit. Whereas an older person or a person with a lesser immune response will obviously have a problem fighting it, because fighting disease is basically an antibody response to an antigen. And we still have to look at some research. In fact, there are many questions concerning the virus. It's still a novel, meaning new virus. So as we go on, scientists are beginning to learn a little more about the virus. I even saw that the WHO has put some guidelines with respect to the disposal of persons who have died. And in one of their comments, they indicated that they are seeing it sometimes, the secretions, the virus, they're isolating from feces. So as we go on and on, we will see more and more, we'll hear more and more. But basically, and this is, I think, what happens, you can contact the virus because of those little fine secretions. It's a secretion type virus. And this is why, although we said it's not airborne, you have to wear a mask because we have to be very careful. There are many procedures, for example, done by dentists, they use fine drills. Many of the medical professionals who use, for example, things like they breed for diabetics, or drills like orthopedic surgeons, they are fine mists of aerosol type secretions that could actually be spread in a person who has a COVID-19 infection. So therefore, we have to be very careful of this fine mist or aerosol type activity, and that is why we recommend that there's proper protective equipment must be worn by all medical persons who are using these fine aerosol type possibility in their practice. I mean, dentists are one of those type of healthcare professionals that we recommend that you have to be very careful in terms of the patients that you're operating on in emergencies, because during the isolation and during the time that people are home, they will have problems. You will get people with cardiac disease who get heart attacks, people who have problems, and now that they're home and eating you know, a very all types of food. You would have people with caries, you would have people with emergency dental problems. So it's not that you say, well, we wait until COVID is finished before normal activities in terms of healthcare requests from ordinary medical conditions. And when I say ordinary, they could be potentially dangerous. Now we see, for example, in the last few days, there were at least 5 persons who went to hospitals and they didn't get accepted into hospitals because the hospitals were overwhelmed. And they had I think there were 3 deaths recently arising out of that. In fact, recently there was a pregnant lady who actually had a normal pregnancy and she had problems getting into the hospital. Recently on the news, even today, we saw that there were problems where persons, for example, who in the United Kingdom, they had their cancer surgery, prostate surgery, and that was deferred until a much later date. And there were many questions as to why cancer is not being cancer surgery or urgent cancer surgery is not being done. And as a matter of fact, in that particular hospital, they use the operating theaters for the ventilators for the critical ICU patients related to the coronavirus infections. So in terms of medical care, in terms of there's going to be, obviously, we have never in our generation and in the past 3 generations witnessed such an excessive pandemic. So medical care and medical activities and how the virus is evolving and has evolved, we still have a lot to learn. And I think that's part of the whole overall problem with what is happening with this COVID-19. So there are many issues pertaining to the medical treatment. For example, it's a community, highly possible for communities to be affected and they do not know it. And I think this is something that we have to grapple with, and we're seeing it in countries where there are quite a large number of tests being done, because the tests are really indicators of what is happening in the community. All scientists will understand that we have to test, we have to do experiments, and to do that, we have to perform tests. Based on those tests that we do, then we can get an idea of how the disease is progressing, how we can deal with the disease, what kind of populations the disease is affecting, and how we can probably isolate vulnerable populations. And this was happening even from China, in that there was an identification, there were older persons who were affected. Look at what is happening with Italy. And a very high percentage of those deaths are due to older persons being affected with comorbidities. And because of excellent healthcare in the past, it's actually very ironic that because of excellent healthcare, there's a larger population of older persons in those European countries and indeed in the United States. And therefore they are because of medications, and now look at what is happening. They are more prone to this virus, and it's very interesting. So what we are going to be looking at now is over the next 3 weeks I'm looking at it globally, is there's going to be an escalation in the number of cases that are going to be identified on a global perspective. Many countries themselves are actually tackling it pretty well, and they have lockdown. A lot of when I say lockdown, lockdown seems to be 2 words that are causing a lot of problems in what they mean in different countries. Each country has a different type of legislation when it comes to curfews, states of emergencies, and what exactly they mean by lockdown. But the essential philosophy of this disease and what it's telling us and what is happening is that really and truly we have to stay away from each other physically. And I think that is very important. The philosophy in terms of managing this disease by medical personnel and all persons who are living in this globe right now, in this world, is really a philosophy of saying we have to assume and you have to pretend that every single one of us have the disease. In so doing, that is how the management and the prevention of further spread and the prevention of further mortality with respect to this virus is going to be addressed, no matter what you do. Countries in the world can do what they want, but the fundamental issue here is the individual. That is how we're going to manage it. So basically, when we look at this thing, it's not about managing the disease, it's not about managing the virus, it's not about managing the economy, right? It's about managing the individual. And I think that is the problem. And I think when we come to people, we realize that we are all different. we have a different, all of us have a different perspective, a level of education, and I think social systems are going to have to be looked at very carefully. And in many countries, some states will obviously have to take action to protect persons because they themselves do not want to protect themselves. I think this is where the disease now goes to a social level. So we talked about the pathophysiology or the mechanism, the type of virus, as we talked about, is a coronavirus. We talked about it originated into animals, it evolved actually, and when the experts went and looked at it, we saw that the actual the genetic code of the virus, the actual genome of the virus, was actually a naturally occurring. It is almost every single day for the past how many years, the virus keeps opening locks and closing locks, and eventually they got a part of the angiotensin enzyme molecule in human beings, right, that it was able to get into and started its tricks. And this is where we have reached today. I told you how it, obviously all cases are imported cases because it came from China. And then when it arrived here, it all depends on how countries are going to be, the healthcare systems. Good healthcare systems with a larger age population will see a higher death rate if they didn't pick it up early or they didn't have put enough systems early enough. In countries like our Caribbean countries, obviously we are islands. We are a little more protected with respect to how we, but we have to take drastic action very quickly because the individual is where the treatment of this virus lies. If you wash your hands, if you protect yourselves at home, you protect your family, you protect everyone has it, and you follow the advice of the medical experts, not so much the politicians, but the medical experts, you would actually survive this virus. And you must also remember that in pandemics, people will die. So therefore, one of the problems in terms of the medical treatment is also the psychological treatment of persons. Mental health is very important in terms of the whole definition of good health. It is the absence of physical, mental, and social problems. So therefore, we want to make sure that if you're healthy, you not only have to look at your physical health, which involves a lot of hand washing, staying away from people, understanding how this virus is spreading, educating yourself, following the authorities, following the medical guidance. If you have comorbidities and you have been taking medicine, you have lowered immune system, you're over the age of 65, you have to look at your health. There's a lot of particular toolkits that are available which you could download from the CDC, from WHO, which gives you very good ideas about what to do at your homes, what to do in your communities, how to engage the religious organizations in terms of interment and disposition of bodies, right? We know for a fact now that a body itself is not infectious. In this case, the only infectious problem that we have with a person who have died of COVID-19 is really due to the pathologist handling the lung tissues itself, which is it's going to be highly infective. And now, as I said, we have seen it in feces. So basically, how the mortician, how the mortuary attendants, how the staff at the mortuary, how the engineers look at the ventilation in the mortuary, all of these things are going to be key in terms of preventing infection to the pathologists who may want to do pathological studies or forensic studies on persons who have died. However, once the body is removed from the hospital, it could be given to funeral agencies, but like everything else, they have to follow the protocols of proper sanitation, handling the decedents, making sure that the relatives don't kiss and hug their dead relatives, especially at the viewing of at the funerals. Keep down the numbers, make sure you follow your protocols of social distancing, make sure the older persons don't really go and touch the coffin or view. So there are a number of things that has to be done at a community level, at persons, for example, religious leaders or persons who are going to be doing the prayers, for example, they have to have an idea of what needs to be done because clearly certain things has to be done, right? So I think I've taken you through the sort of the whole cycle, right, from the birth of the virus to the movement of the virus in a medical perspective. Of course, I didn't cover everything. So, I'm sure that if anyone has any questions out there, I'll be happy to, to get them. Organizer, I don't know if you have any questions.
There's only one question thus for Dr. Ramroop. The question comes from Robin Robinson. The question that was posed is, if the virus is zoonotic, does
Yes.
that mean it can be transferred back to animals, let's say pets?
The answer to that, all the research has shown is that pets, it cannot infect pets. Your pets are safe from the virus because the way the virus mutated, there's no evidence to show that it has gone into some of our common animals that we have around. So at this point in time, there's no research or there's no evidence to show that the virus will infect your pets. Now, the problem with pets is that if you have a virus or you have the virus at home, you will have to be careful because you can have the leashes or the chains or whatever it is. Those are the fomites that are on your pets, and when you get infected, you could get infected by a person who may visit your home or may play with your pet at the park who has the virus, and therefore you have to be very careful. The pet itself is not transmitting the virus to the animal. The pet itself will not be affected by the virus on the leash, but you could get the virus by touching the leash soon after, obviously, somebody hands you over the leash. So when you have an illness at home, a cough and a cold, we will advise you not to interfere with your pets. Have someone else take care of your pets. I mean, the thing about it is we don't know what's happening with the virus, but you don't want to have anything happen to your pet because we never know. Just keep them safe.
Okay. The next question that we have again from Robin Robinson is, can a recovered patient be reinfected?
Yes, I think there was a case recently in the United States, and there was one case, I think, in China, in which there was a possibility of reinfection. And it's not, I mean, we haven't understood too much about the antibody response, but I have not seen any research done or any case presentation in any of the big journals. I don't know if our other doctor has seen anything, but I have not seen anything on the British Medical Journal or any of the medical journals with respect to reinfection. We heard about it on the news, we heard about it, we saw it on the internet, but I can't verify that. But as I said, it's a new virus, and we're not sure about the antibody responses yet. But the possibility is that if you're normal and you have had it before, I mean, it could be immune, but again, I can't see.
Okay. The last question is hand sanitizer any good?
The answer to that is yes. The problem is use of it. For example, I'll give you an example of hand sanitization. It's not the tool really, it's how you use the tool, and you have to be very careful. The hand sanitizer obviously has to have about over 60% alcohol in it. That's the first thing. There may be hand sanitizers that have been pushed at 50% or 45%. You have to be very careful. You have to make sure it has enough alcohol content, right, in the hand sanitizer. Right now, for example, in mortuaries and whatever, we're using 70% alcohol solutions to sanitize the tables, the stainless steel tables, and everything else. And that works pretty well, in fact. But the problem with alcohol itself, just like that, is harsh to your hands. And you have to be very careful in terms of what it does to your tissues if you have any cuts or lacerations. It's very, very naughty. So, but in terms of alcohol sanitizers, yes, but again, it's how to use it. For example, when you come out of a vehicle or you go into a vehicle after visiting a store or something, you touch your door handle. Then you go into your vehicle and you take your hand sanitizer and you sanitize. Now, a lot of us might take all the phones from our back pocket before that, so we have to look at the phones as well. Then when you sanitize and you're driving and you reach home, as you come out, you close the door, you might touch your handle again. So which means you have the virus on your hand again. You go into your house and you open your tap. You open your tap with the hand, with the virus. You open your tap. Most of the taps that we have in our homes are, you take your hand and you actually have to open the tap. Then you wash your hands with soap and then you touch the same tap that you put the virus on. You see, so again, you have to be very careful. So, I mean, in hospitals, we have the elbow taps. Like I'm a surgeon, you're accustomed using your elbow taps. And a good thing to do would be to set up a little area in your home so that it becomes almost like a sanitization area before you enter. In that, you have to put a garbage bin, make sure you have some napkins, right? Get a container with a spray with about 5 tablespoons of Clorox in a gallon of water, shake it up, put it into the spray. And prior to using the tap, you could probably spray the tap or use the napkin. And that is what some of us do when we go to public washrooms. We have quite a lot of persons now. Not everybody does it, but some of us do it. And for example, we use a napkin. We open the tap, we wash our hands, right? Then we pull a new napkin from the thing. Then you close the tap, and then when you're coming out of the washroom, you use your feet. Or if most of the proper washrooms do not have doors, but then quite a lot of restaurants right now have doors. So you can actually, what I do is I take a piece of the napkin, a fresh piece, open the door, use my foot, crumple the napkin, and throw it in the dustbin where I can get them. So now you might have to put different things in your home. Put a garbage bin outside of your toilet door, and make sure that when you go in, you use these disposable napkins. Open your tap with it, right? Throw it away, wash your hands, close back the tap, throw it away. I mean, these are things that, you think about the tool. Yes, hand sanitization is good, but then it's how you use it. And of course, touching your face. The virus obviously gets into your body through your nasal passages and affects your lungs. The virus can get into your body if it goes into any other orifice, but it doesn't affect those tissues. It seems to have an affinity for the lung tissue. So therefore, if it spreads around the nose or it's there, we have not heard much about washing your face. As a matter of fact, I remember just recently, a couple of days ago, I collected some money from a person who was coughing in my office. And then I remember I forgot about that, he was coughing. I put the money in my pocket, and I actually touched my nose. So you have to be careful, because you touch your face, over 50 to 60 times in any 1 hour, and even more in some studies. And I actually, when I remembered, I said, oh my God. So I went and I washed my face with soap and water. I washed my hands, and this was about 2 weeks ago. Thank God I haven't really picked up any cough or cold since then. But it is something that you have to remember, because we tend to automatically do that. We collect the money. We touch our phones. You remove your phone, and your phone might have the bug in it, and therefore most of us don't sanitize our phones. We have not been hearing much about washing and in terms of viral load. So, for example, if you have a good immune system, right, and you wash your face soon after you think you touched it from an infected person, how much of that virus could actually cause the disease? We're not sure about the amount that will get in. And if your immune system, clearly, I think if you have large amounts of virus, your immune system might be overwhelmed. And if you have a smaller amount of virus, it should, by all common sense, it might have a lesser viral load. That is really non-scientific, but it's something that we might want to think of, in the event that we're looking at going forward. Because as I said before, these are the simple little things that actually cause disease. And we saw this, for example, in healthcare personnel. Because healthcare personnel, for example, these are the little mistakes that they make that cause them to be infected. They have all the PPE, and they are more protected than us on the outside as physicians who might have practices. But it is the little small things that we forget, and I think this is what we do. In answer to the question about hand sanitization, it's not just hand sanitization, it's how you do it and the sequence of activities. And you have to be a little more critical, especially in the healthcare sector. And that is why we have all the doctors are dying in Italy. And that is why we have one case, for example, in Tobago of a healthcare personnel who has gotten infected. See, we're not sure if that person traveled or she contacted the disease through contact with another person, but it's a high-risk case. Healthcare personnel high risk. It is because of a procedural issue. For example, when you take off your mask, when do you do it? Do you take it after you're gone? Or do you take off your gloves? Do you double glove? And when you take it off, do you take off your mask from the front or the back? And when you throw your mask down, how do you wash your hands? Do you wash your hands after you come on? Now, these are the simple things that we have to look at in terms of donning and doffing. When it comes to hand sanitization, it's similar.
Okay, perfect. Next question. We'll take a couple more questions until 7:20, and then we'll transfer over to Dr. Vijayakumar. So the next question that I have for you, Dr. Ramroop, is: in a regular setting, not healthcare, can it be airborne transmitted?
The answer to that, as I said, I looked at the recent research coming out of it. The answer to that, they have said it's not airborne in terms of lingering in the air, for example, in a room, and then you come and you catch it. What actually is, because the secretions, the actual size is a little bigger, we don't expect it to be hanging around too long, and therefore, like some of the other viruses like SARS, where you can contact it by airborne transfer, it is not. This is not as airborne. What remains in the air is the secretion. So Most of the recent research are saying is much more due to the secretions in the air. But airborne is something you have to be very careful. It's not fully airborne in terms of the virus will come across and stay there. So when you come in and you breathe it in, you get it. That's what we mean by that. What we mean by airborne is that if we cough and we have the virus and it comes across in the air and you are there within 6 feet of it, you can get it if you're not protected. And that getting the virus is because of the secretions that the person secrete when he coughs. You understand? Yeah.
Cool. Is there a possibility that the virus will mutate during the current pandemic?
I think that because of the way that nowadays we have very good medical care, supportive care, and I think that we have never seen that sort of mutation. I mean, we looked at some of the old reports from the 1918 virus, the Spanish flu, and basically none of the evidence that came from it showed that it actually mutated whilst during the pandemic. I don't think that it will. I'm not that kind of person. I'm a scientist. I can't really comment on that. I probably need to speak more, maybe to get the expertise of more persons more involved in genetic research and virology research. So all I can say is I don't think it will happen from my knowledge, but I'm subject to correction.
Okay. Next question. I understand that the right treatment right now is individually based. How has the vaccination research been doing?
Well, so far, I understand. Again, none of it is, when I talk to you, I'm like you out there right now looking at the internet. Some of my colleagues, some my classmates, for example, from the United States, from my class in Mona, Jamaica, they are involved in research. So we still speak on our little WhatsApp chat. So we are kind of up to date in what's happening in the UK. Many of them work in very large, big labs in the United States. And so far, they have reached the stage where there are some of the vaccinations have been prepared, but the testing phase of the vaccinations would take a little while because, as you know, it has to go through a process in terms of animals, and after the animals, then they'll have to look at human research. So most of the commentators, most of the scientists are saying we don't expect to see a vaccination in any sort of short time. It probably take between 6 months to a year.
Okay, thank you. What precautions do you give to the family members that live with an infection patient in their house?
The first thing is that you have to be careful in terms of how you treat with this person. Right now, all of us, we are going to, we venture out sometimes, and everybody's angry with each other. Everybody seems to be protecting their 6 feet space. Cashiers, for example, are treating you like lepers. They're not smiling with you. Customer service is going down. People are getting worried when you cough or you have a dry cough due to using statins or something, and you have this chronic cough for years and bronchitis and you cough. What I'm trying to say is that you have to be careful that you don't mentally make this person depressed by treating them as a leper. I think that is one of the first things you have to do. You don't have to isolate them in terms of psychologically. You have to be very careful. Sometimes you forget that, and I've seen that. Today I saw it at in one of my patients. I had to do a home visit, a lady with a fracture, and she was home, and there was a guy who came down from another country, one of their relatives. And you have to be very careful with that. So I advise them to be careful with that. Of course, you have to make sure that they're isolated, and you have to treat everybody as if they have the infection. So in the house, you yourself would have to make sure you have your soap and water. Soap and water is the cheapest thing. And just as I just told you there about taps, for example, you have to be careful of the use of the taps. When you go in, as I said, keep pets away from the person. Keep them in their room if as much as possible, right? Their clothes could be washed with everybody else's clothes. There's no problem. Detergent kills everything, right? So in terms of this, you don't have to dispose clothes. It's not like that. But you have to make sure that when you take the clothes out of the room, you wash the clothes. You can wash it with everybody else's clothes. Make sure and wash your hands with soap and water after. Especially when you're dealing with the patient, you're preparing their meals and you're giving them their food. There's nothing wrong. Just remember that when they finish, you have to wash your wares with detergents. And don't get scared. It's just you just have to follow the instructions. Wash your hands. Make sure you don't have to protect yourself. If the person has a cough and a cold, that person should be wearing a mask, right? Same thing I told you about using the little protocols so that, you know, if you're leaving the room, your hands sanitized, you can marry you have to, he has to go to the washroom, so that if he doesn't have or she doesn't have his own washroom, you have to actually now make sure that there's when the person uses the washroom, then whoever comes to use the washroom, you can use 5 tablespoons of Clorox in 1 gallon of water, right? Sanitize all the door handles and everything else before the washroom is being used by others. If there are no other washrooms in the house, emergencies would dictate that, you know, you have to use it soon after. Well, fine, there's no problem. All you have to do is when you finish, right, make sure you take your wash your hands, right, with soap and water, and follow for proper washing. You have to be extra careful. And then once a person, if he's not that ill and he has a mild viral symptom, well, then you're lucky. If the person then begins to get a bit ill, call a doctor before going. Don't just take the person to the doctor. Call your physician, call number. Most countries have a hotline number to your doctor. Call the doctor, speak to the doctor. A patient just called me, I'm an orthopedic surgeon. He came to my office, I was home. When I asked him what is the problem, he said, well, you know, I have a cough and a cold. I said, well, you know, I'm not that kind of doctor, but I gave him the hotline number. I also referred him to the general practitioner up the road. So, you know, even if you call your close doctor who may not be a general practitioner who deals with fever, he or she will advise you. So call someone that you know, call a nurse, call somebody if you're worried that the person may need further care. If the person, you don't wait until the person begins to have a problem, especially if it's an old person. You must know that when they begin to have a little short of breath, there's been propagating a little test that a lot of it's not scientifically verified, but they say that if you hold your breath for a minute and you keep it there, you don't have too much lung problems. But that is a simple test that we do in many of our offices in terms of identifying whether or not you have problems with your lungs in terms of vital capacity and the amount of air that you can breathe in and hold. It's a simple clinical test that we use. So if you can hold your breath for a little while, it means that you don't have too much of a problem. Now, when the person is really in need of help, once you call the hotline number, the health sector, the protocols would involve will allow that the person be admitted and tested. Right now in our country, we're not doing any sort of community testing, but if the person has a direct contact or has been in contact with someone who traveled, then they will do the test. They don't do the test at home. They will admit the person to one of the centers of where the quarantine centers, and then they will observe the person once he or she has symptoms. So really and truly, that's the sort of progression. One of the things you have to be, well, I mean, I'm going to add this because it's a reality. One of the things about this virus is that if you have an old person who may have the virus, and that's why I started off with loving the person and showing him some caring or her, because the problem is that you may never see that person again. Once they go into a quarantine, and if the symptoms become worse, they go into the ICU. Because of the current protocols, because of the current problems, having family go to meet with these people, it's difficult. And when they pass, you don't see them obviously again, right? They will come home only as a corpse. So it might be harsh saying that, but it's a reality. So that is why, as I said, show love, show compassion, and treat those persons not as lepers, but as your family, and that's a very important message.
Okay, thank you, Dr. Ramroop. The remainder of questions that were posed, we will answer them in the last, after Dr. Vijayakumar is completed, in the last question and answer segment. Dr. Ramroop, thank you again once for your participation and for sharing all of this information. And we look forward to having some more medically answered questions at the end of this session, where we would have a 15-20 minute segment just to answer questions. So we'd like to welcome, thanks again, Dr. Ramroop.
Thank you very much. You can take off my screen.
No problem.
That's all right. Yep. Yes. Thank you.
No problem. So thank you, Dr. Ramroop, once again. Our next presenter is going to be Dr. Vijayakumar. Let me just unmute him. Hi, Vijay. Are you available? Are you hearing me? Vijay, do you hear me? Are you getting me?
I'm available. I think you need to click on the other person.
Okay, cool. Let me just.
Remember,
Are you? Yeah, no problem. Cool. So you got both of them. Are you available now? Are you hearing my audio now? Perfect. Or good. Perfect.
Yes.
Thank you. So let me just say, Dr. Vijayakumar, PhD, is a globally recognized expert for contamination control, aerosols, filter media, and filtration, with several patents and over 30 years experience in industry and research. He is an he is a founder and chief instigator of his consulting firm, Airfill, with clients around the world, including NASA, for their filtrations in space habitat. He is currently a distinguished visiting professor for the Chinese Academy of Building Research. His other professional activities include lecturing at the University of Minnesota, short course on air filtration, and for the ASHRAE Distinguished Lecture Program. He helped design and taught the ASHRAE Clean Room Certification Program. He is also the chair of ISO and IEST committees for higher efficiency filtration standardization. Vijay, as he is commonly known, is the author of an iBook on aerosol mechanics for non-scientists and is always available to educate and mentor anyone who asks. Dr. Vijayakumar is also the co-author of ASHRAE Clean Room Design Guide with a PhD in mechanical engineering and particle technology. Let's welcome Dr. Vijayakumar. We will keep with the same standard of questions will be asked after, or you can post your questions in the question section, and we will open the question and answer segments at the end of the session. Thank you. Vijay, back to you.
Thanks, Karen. Thanks, everybody, for coming on a Friday evening. Hopefully, you learned something, and I learned something from your questions, because I firmly believe every interaction is a two-way street. And Dr. Ramroop set the stage, kind of an overview from the medical side of it, and I'm going to take over from where he left off, focusing on my expertise, which is the contamination control in the air, especially the airborne, both the short distance as well as the large distance. As he outlined, and most of us have read in the news, the challenge is immense. It's global, it is severe, and if you listen to some of the news conferences by the governors in the US, potentially we could have 30,000 people in the ICUs. So what we need as professionals, each with our own set of expertise, we need a sound response based on science. Even if we did all of it, there is no guarantee it's going to work. With that little bit of a ominous caution, I'll quickly go through the options we have. From a purely air point of view, air quality control, especially indoors point of view, we have two main options. Source control, make sure you don't get any contaminant, mainly this virus or anything associated with it, and controlling the facility through clean air, airflow, and the layout of how you set up your facility. And one of the things I try to at least point out, some of these things may be difficult to achieve in existing facilities, say your office or a school or your workshop and so on. Of the options we have, source control is the best. This is true of any contaminant. If you don't have contaminant to start with, you don't need to protect it. You don't need to clean it. You don't need to save each other from it. So this is doubly true in a pandemic like this, especially when it's going through the air. So the three main things we can talk about is the protective gear. How do you protect the virus from coming out of wherever the sources are, mainly the people, and the exit and entry restrictions, so that people who are infected or who are carrying the infection don't come in, and those who are in with the infection don't go out. The second part most of us understand. that if you're infected, if you're in ICU, you're in a protected environment. You don't let you out. But like Dr. Ramroop was saying, what about the entry? If you don't take proper care, the procedure, the sequence of gowning and doffing and downing, we have problems. How about restricted items? Some of it we can control, some we cannot control. So those are things we can talk about. Some, especially the restricted items, are a little bit specific to each case. So I'd leave that to the experts in the next 3 or 4 webinars. This is common in most healthcare, now even in regular life. 80% of the problem we have coming into any clean space or uncontaminated space is poor hygiene. 80%. And most of it can be taken care of if you wash your hands. And the biggest offenders, especially if you ask the nurses in most hospitals, the biggest offenders of not washing hands are doctors. Think about it. The one you trust your life with are the ones most likely will not wash your hands. So that's the biggest source of contaminant coming into your clean space. If you're a patient or if you're already in a building with somebody who needs attention and a doctor comes in. So biggest advice I can give you is if you are in a hospital setting and if you think you're sick or if you're admitted, if a doctor or anybody comes in, especially the healthcare provider, if they have not washed their hands, make sure they wash their hands. And it doesn't hurt to have a hand sanitizer next to you in case they don't wash their hands. I'll touch a little bit more about the face mask. This seems to be a big debate. Either we have too much, everybody and their uncle are sewing masks in the house, and so forth. If you look at the types of face masks you can buy or you can get in the different supply houses and the protection they offer, the more expensive they are, the more protection they offer. If you look on the right extreme, that's a military style face mask. We call it a full face mask. It covers your face, entire face. It protects all your breathing. Typically has two filters. And if you look at I don't know if you can see my pointer, we call this the diaphragm that comes in multiple sizes depending on the size of your face. That's an extremely tough protocol that a mask is fitted to each person. It's like your shoes, and they make sure it fits you, that there is no leak around this diaphragm and your face. If it leaks, it does not matter how good your filters are in your mask, they're not going to be as effective. And the one next to it is very similar to the big mask, except here it does not cover your face, just the nose and your mouth. Otherwise, it functions the same. You'll find a lot of first responders, EMTs, going into hazardous places will wear that. It's about quite expensive. And the one next to it is in many cases very common because it's got little pump and it's got replaceable high performance filters. It blows air over your face. So the face itself your nose itself is free, but your face is covered in a sheet of clean air. So it protects you from anything going in simply because air is flowing this way. It'll be tough for something to go from bottom to the top. Those are the masks which give you the most protection. Unfortunately, they are not commonly used. The two ones on the left, the extreme left, we call it the surgical face mask, the least expensive. It looks like a bandana or a handkerchief around your face. And the one next to it is the molded mask, the one you'll find in a hardware store. Workers wear it when they work in woodworking. It's a little like an eye cup go around your face, and you fasten it around your ears with a rubber band. So let's look at the most common one. the surgical face mask, the bandana type. On the left, if you look, here is a person coughing, which is what Dr. Ramroop was saying. If he is infected, all the virus, all the stuff, the spittoon gets to the next person, which is about 6 feet away. Much beyond 6 feet, it doesn't matter because the drops are so big, they drop to the ground simply due to gravity, which is where this miraculous 6 feet comes from. Depends on how powerful your cough is. Most of them drop off before about 4.5 feet. 6 feet gives you a margin of safety. What happens if I put on the mask, if I'm infected, if I put on a mask? It acts like a barrier. Suddenly nothing goes much beyond my nose. Most of it goes straight to the ground. So this offers a great amount of protection if you're sick and if you're coughing. It protects the non-infected person around you, which is why those of you who have been to Japan especially, or Korea, you'll find people who are sick, they've got a cough or a cold, they always walk around with a mask around your nose. It's not because they're protecting themselves, they're protecting you, the people around them. So it's a very good device for the ill if they want to be surrounded by the non-ill people. So that's something to remember. What about the same mask when you want to inhale, which means you're a healthy person, you want to protect yourself? Take a good look at this picture. What do you see? You see there's a lot of gap around the face. All these are leaks. So if you're a medical professional dealing with a patient, he or she is going to cough, or if you're a surgeon, which is where the term comes from as a surgical face mask, when you're cutting through the person, the blood may spurt out. If you're an orthopedic surgeon like Dr. Ramroop, you may have bone chips flying out. This mask is very good for protecting it because most of them come very close. You're very close to the patient. So it provides some amount of shielding. So it works very well for the medical staff. What about you and me? If I wear it and go out, look at all the leaks here. It does not give you much protection at all. And especially this particular example, she is not wearing a mask with any fit. There's huge chunks of openings here through which air will go through. So if she's close to a person infected, the mask does not do anything. But it does offer a feel-good psychological benefit because half the fight in a battle against the virus you can win if you feel good. So I'm not discounting it completely. You wear it for psychological reasons, not for medical protection or inhalation protection. So if there is a shortage of these masks in your community, the best advice I can give you purely from an air quality point of view is save these masks for those that are going to help us because it doesn't do us much good. So keep that in mind. So those are the ways we protect the people coming in to our facility. If you're sick or if you're ill, protect others around you. So we're protecting the source from coming into clean spaces or non-infected spaces. The second thing in our toolbox is how do you manage your facility and your system? Here, when I say facility, I'm talking of any building, any room, could be a hospital, could be a ward, could be a school. The principles I'll walk you through applies to any one of these. Of course, the quality and the rigorous designs may change, but the intent is the same. The tools we have at our disposal for these are clean air. How clean do you want to keep your air? And how much and how and what directions do you control it? And finally, how do you manage the layout? Where do you put your patient? Or if you are running a school after we're all out of the shutdown, where do you put your classrooms compared to where your lab is and so forth? The main goal of anything we do from an air quality point of view is you want to prevent the particle-patient interaction. Here I'm using the term particle generically to include all kinds of bioorganisms, virus, in this particular case, the COVID, but it could be anything. And then once you have these particles, the second goal is to scavenge them. You don't want them staying in your room, continuing to infect. If you go back and look at the mask I showed you, it gets rid of the contaminant coming out of your mouth by pushing it down to the floor. And ultimately, minimizing the particle source, not just coming from the humans, but it could be how do you sweep the floor, how do you mop the floor. Now that we've sent all these viruses to the floor, if you don't take care in mopping your floor, you're going to re-entrain them in the air. So those are things we have to be careful. These are two rules I'd like to reinforce on everybody, especially those who are managing or reconfiguring your facility. If you start out with a poor layout, if you have, let's say, your sick patient at the entrance of the hospital and all your surgeons at the back, you cannot fix it by simply changing or improving your HVAC systems with better filtration. Or if you have no airflow or very poor airflow, you cannot simply change it by changing your layout. I remember one time back in the Philippines years ago, we went into a facility. They had a very nice setup, except to conserve energy, they shut off all the airflow. And they decided to upgrade their filtration, thinking they'll be in good shape in terms of cleanliness. So that's your problem. If you're not careful in thinking through what is it you're trying to do, the poor airflow will not overcome all your other mistakes. A little bit on filtration. This is something new to people who are not used to filtration. If you take most HEPA filtration, the high efficiency filtration, or any fibrous filtration, which is just about any filtration we use for air, the performance, the efficiency by which these filters remove contaminants or particles changes with particle size. As the particle sizes go up, starting from the left, the efficiency keeps dropping up to a certain point and then starts going back up. Most of us can understand that the efficiency of a filter goes up when the particle size gets bigger. And bigger the contaminant, bigger the drop, easier to get removed by a filter. What is more difficult to understand is that is true that when the particles get smaller, it still gets more readily captured. So in filtration, we call this minimum spot as the most penetrating particle size. In other words, that's the worst case for a filter, which means particles are a virus in this case, bigger or smaller than that particular size, will be more effectively captured. So that's the Mother Nature once in a way gives us help. So for most traditional filters used in, say, face masks or the HVAC types filtration, the minimum size tends to be around about 0.2 microns or 200 nanometers, a little bit bigger than the COVID virus, which I believe Dr. Ramroop can correct me. It's around about 100 and 120 nanometers, 0.1 to 0.12 microns. So you can see right off, these viruses are going to be more readily captured by that filter than its specification. In other words, if you get a 99.5% filter, it'll probably capture 99.995% of the viruses. So Mother Nature is helping us. So keep the number, the 0.2 micron, the worst case size varies, not only with the type of filter you use, the type of face mask you use, but the flow. The more you breathe, the the size changes. As for a little bit of a reference, you get a variety of filters if you go to the store to buy the kind of filters for the depending on the applications you have. The larger the particle, the cheaper and the more coarse the filters. Way in the right extreme, especially if you have central air conditioning, this is the kind of filters you use. It doesn't do much good in terms of removing particles or viruses. And if you look at this particular device, a bunch of these devices, you'll find these in hospitals, sometimes in surgeries. You'll definitely find it in quarantine facilities. They used a ton of these when they were trying to isolate patients during Ebola. So it ranges in performance. And the graph I showed you before in the previous slide, this 0.2 micron refers to this kind of a filter. So now I've given you a quick overview of what and how we can clean the air going in. So the next question, just cleaning the air alone is not enough. Like I said, if you don't have any airflow, all the high performance filters gives you no benefit. So ultimately we want clean air delivered, which is what we are interested in. How much clean air do we need in this particular room? How much can we deliver? So the clean air delivery rate, in other words, how much clean air can we deliver in a unit time, depends on the flow rate times the efficiency. If it is zero efficiency, which means you just open the window, the clean air delivery rate is zero because there is no removal of contaminant. So you can achieve it two different ways. Either you can get high efficiency or low flow, or low efficiency and high flow. To give you an example, you can have 100 CFM airflow through a filter at 90%, which gives you the same clean air flow rate as 120 CFM and 75%. And if you're, these are not typical numbers for a face mask, if you're breathing through a face mask, lower the resistance, easier it is for you to breathe. So it's always a trade-off. If you look at the surgical face mask, it has hardly any resistance and very low efficiency, probably like 80% efficient, but it's very easy to breathe. Whereas if you look at the military style full face mask, the resistance is very high. It's very difficult to breathe, but the flow rate is very low. So the clean air is very clean. So especially if you're retrofit, lower efficiency and higher flow, in my opinion, is a better option, because not only the higher airflow helps scavenge particles or contaminants much better than low airflow. Think about it, when you want to blow your leaf on your garden, or if you want to blow stuff off your table, a stronger airflow is much easier to get rid of these debris than low airflow. So higher airflow, lower efficiency always gives you better outcome. And they also tell me psychologically, higher airflow also gives you better psychological feeling of comfort, because first thing we do when it's really hot, we turn on the fan because we want to feel the airflow on our face. And this, I'm spending time reinforcing this because this is a good way to look at existing buildings. If you are planning to convert after all this crisis is over in your office, if you're looking to convert it, your HVAC system to get better contamination control, it may be easier for us to keep the airflow the same or higher and use a lower efficiency filter without having to redo the entire HVAC system. Then now we have talked about the flow rate. We've talked about the efficiency by which you clean the airflow and the product of the two to give you the flow rate, the clean air delivery rate. Now we have to worry about the direction of the flow, which is something a lot of people misunderstand, misuse, or forget about. if you take this particular case, and if you think of this as a patient, for example, and this is the virus, and air is flowing from the top, the virus just gets pumped out because somebody is coughing, and the airflow simply scavenges to the back. We call this as a unidirectional flow, which means all the stuff coming out of this source could be a cough, could be your breathing, if you're sick, if you're a surgical theater, stuff coming off the patient, or if you're a process making medication, the stuff coming out of the operator, they all get scavenged. This is the best way to scavenge what is created inside a room, but not commonly used in healthcare except in a few high-end, I would say, joint surgery. I don't know if Dr. Ramroop have experienced that. This is more common when your airflow is not nice and straight going top to bottom. It's kind of turbulent. What happens? The airflow will not scavenge the virus coming out of the patient. It stays in place for a longer period of time. So eventually you're entraining this airflow, the contaminant, increasing the odds that you're going to infect the person next to you, or it's going to stay in the room long enough that somebody else is going to come and breathe into it. So this is very common in most current settings in hospitals, in hospital wards, including the ICUs, because it's very difficult to create the kind of the unidirectional flow I showed you a couple of slides ago, because you have to start from scratch. And this is very common. This is probably the most common ward you'll find, or even your house or your office. You'll find an air filtration system up on top, supplied with air from a central air handler. Here is the patient. Here could be this, if you're working in an office, it could be you. It could be the teacher in the lab, school, what have you. And the return air, if you're in an enclosed indoor room, you'll have both an inlet air and return air. The return air very often is in the top. Why? Because it's easier to build. I can put all the stuff up on my ceiling. I don't need to spend the extra cost of putting it at the bottom. So what happens if I set it up this way? The air goes from the left to the right, from the inlet to the outlet. What happens to the person below? Here is your patient. They get nothing. The airflow, nice air conditioned, clean air, filtered air, cleans the ceiling, leaving the patients and all the people operating underneath to suffer, because they get no benefit of the airflow. Now what happens if I move the return air to the bottom? From the top, I move it to the bottom. Suddenly the airflow is straightened out. I'm getting the airflow from the top going out the bottom. So I have some sweep of clean air, conditioned air across the space. It could be the patient, it could be your coronavirus infected person. So stuff comes here and goes out. Now, if you're the healthcare provider, if you want to protect yourself from what's coming from the patient, you want to stay upstream of the airflow, which means you get the first dibs on the clean air, then it goes to the patient, and then it gets scavenged out. On the other hand, if you want to protect the patient from yourself, then you go on downstream side. So you're sick, you don't want your stuff to go to the patient. So depending on the condition in which you're treating your patient, you got to make sure the location is one or the other side of the healthcare provider or the attendant. For example, if you're in a NICU, the child, the infant, is highly compromised. You don't ever want the attendant upstream of the NICU, the incubator, because you don't want to expose that child any kind of extra burden coming from the medical professional. No matter how clean they are going to have some contaminant. This is an interesting layout for a clean airflow system in a hospital. Both the inlet and the exhaust are from the top. You get a nice loop going around from the top. There are some school of thought that if the airflow is coming at a high velocity, it's going to provide some amount of scavenging. If you have a room like this, I don't recommend for a hospital setting, not even for a school setting, because it may be slightly better than having the return air up on top. It may have some amount of scavenging here, but it still leaves everybody unprotected. There is a good tendency to suck in contaminant from the floor back on top and infect or reinfect the patient. So not recommended. The easiest in all these cases, I didn't show you the details of it. In all these cases, if you're retrofitting an existing building, easiest way to do that is try to move the return air either permanently or by using flexible ductwork to a place where you will get, in this particular case, if here is your inlet, you want this particular return air to go to this spot. If you can have a flexible air hose, you can move it out here and you'll still get the same benefit. It's not ideal, but in a short order, that's something that will give you more protection. It may not look pretty. So before we wind up, typically these are questions that come up. These are examples of 4 different types of cascaded rooms, especially applicable to hospital. If you look at, depending on where you want the protection to be, we call this as a flow in. Here is your infected person. You don't want anything coming out, so everything goes in one way. Typically, you'll have an anteroom, so that it's like a double-walled entry. And it's the other way around. Here, they're not infected, but they're compromised. Say a burn victim, NICU. You want everything going out. You don't want anything going in, because they're in a highly vulnerable, compromised state. Here, it's very similar, but it's protected both ways. You want to protect them with clean air. You want to protect yourself. So depending on what you want, you can use the same room by simply changing the flow direction. You can protect you from the patient or the patient from you, or both of us from everybody else. I'd like to throw this in short order. If you want a really clean space because somebody's need to be treated right away, we call this as a soft wall enclosure. It's like a tent with clean air up on top, and you got curtains on the side. But simply by opening and closing the bottom, you can control which way the air is flowing. Especially if you're a first responder in a field setting, this concept is being used. I don't know if it's common in the West Indies. I've seen some of it used by the hazmat people when you have a chemical spill. So in closing, the best option is to control the source. Given that we cannot stop getting sick, the best thing we do is, hey, wash your hands. Make sure if you forget to wash your hands some more. Make sure if you're infected, make sure you stay away from healthy people. That's the distancing. That's the only way we can prevent the source from contaminating us. And the face mask, you wear it if you have plenty of supply, more for psychological benefit, but save the best for the medical staff so they can help us. And if you're retrofitting, especially Higher flow, lower efficiency is a better option, although it may not be as sexy as getting a HEPA filter installed. And don't forget, return air is a fantastic and simple tool to control where you want your contaminations to go. So, any questions?
Yes, we do have a couple of questions, Dr. Vijay. First question, what is the difference between an N95 and an N99 mask?
Little step back. If you look, those are American grades. I don't know what the equivalents are in the UK or other parts of the world. N means it is not resistant to oil or liquids, which means it's the lowest grade of masks you can buy. R is the step up, which is resistant to oil but not completely impervious. P is the pure 100% resistant to everything. That's typically what you want if you want 100% protection. The 95 means it's 95% efficient when tested with sodium chloride aerosol. All the N's are tested with a salt material, whereas the P is tested with oil. If I test an N with the oil, then N95 will probably end up being like a 20% efficient filter. So part of that is because most of the N95, I would say all of the N95 masks you find, whether it's the surgical or the molded mask, they are made with material that carries a charge in it. And the charge, once you start using, decays. So the N95 keeps dropping in performance. So rightfully, unless it's not marked, most of the good manufacturers will mark it as single use. If you wear it, you take it out, you got to throw it away. You cannot reuse it because at that point it's unknown quantity.
Okay. The next question was the same question about N95s. How effective are the N95 masks?
I think I just mentioned the material is 95% efficient using the sodium chloride aerosol. When you make it into a mask, like the ones I showed you with that, like the bandana type, if you don't have any fit, if you have a leak all around your face, it's virtually worthless. So it's not effective at all. So the closer you fit it, the better it is. But the leaks are so, it's impossible to seal it around your face. So I always think it's better for your psychological well-being than for the true inhalation protection, except if you're the surgeon or the doctor working close quarters with the patient.
Okay. The next question that we have for you, Vijay, is what is the size of the coronavirus? And HEPA ULPA also, does a certain type of UVC kill this virus?
Two questions. I believe that this is something Dr. Ramroop can correct me. What I've read is most viruses are between 90 to 120 nanometers, 0.09 to 1.12 micron. What I've seen is the coronavirus is somewhere around 100 nanometers, plus or minus. Okay. Dr. Ramroop can correct me if I'm correct. ULPA filters, it's not ultraviolet. ULPA filters simply means it's better than HEPA filters. HEPA filters are 99.97 or 99.99%. Anything better than that, we call it ULPA filters or ultra low penetration filters. Typically used in clean rooms, microelectronics.
Okay, cool. Next question is actually a statement from our RP chair from Caricom, Dev. I don't get why HEPA filters curves goes back up, increasing efficiency below a given particle, size of 0.2 nanometer. A small particle should go through unfiltered. Shouldn't all okay. Should small particles go through unfiltered?
Yeah. So this is for the lay person. This is always the paradox. It's difficult intuitively to understand why it's more efficient at smaller sizes. Maybe I need to give a separate workshop on it. It's simply in short order, the small particles behave like molecules, which means they're moving all over the place very, very rapidly, and they get collected. So the smaller the particles, more readily they get collected. So if you take a typical HEPA filter at 99.9% at 0.2 micron, at 0.1 micron, it's going to be at least another order of magnitude more efficient. So
the next question that we have.
So did I answer that question? I think it's a tough concept.
Yes, it is. I'm hoping that Deb will ask another question to let me know whether the question was answered or not.
Yeah, if you have other questions, I'll try and pull up a slide on that while Dr. Ramroop is answering other questions. Then we can show it before we hang out.
No problem. Sounds good. The next question is, I have a question about the N95 mask with the breathe easy mask valve in the front. I think the valve closes when you breathe in, but opens when you breathe out. Are these type of masks safe for sick persons to use?
My personal opinion, if you're a sick person, you should not use it. But people will, I know at least half the mask manufacturers will disagree with me. I'm saying that for two reasons. One, those masks don't really offer you much protection in the first case anyway, because of the leak around your face. So if you look at the effectiveness of a mask, N95 mask, if you wear, the effectiveness at your nose is probably like N10 because of the leak. So if you are sick, you're wearing it thinking you're going to protect, but you're breathing out through the valve, you're infecting everybody else.
Okay, next question that I have for you, Vijay, is, can unfiltered natural ventilation be used in spaces used to quarantine COVID-19 patients?
Oh my goodness, probably not.
Absolutely.
I'd leave that to the medical professionals. From
Okay,
a purely air quality point of view, if you're outside air, if you're guaranteed it's clean, I don't see why not, as long as once it comes into the patient's room, you don't discharge it in to the hospital or back outside. You have to filter it before you exhaust
it. To complement air filters, what does the research say on the UVC and COVID-19?
Again, this is maybe one of the other speakers will tell you, but I can tell you in general about UV. If you look at most of these materials used in filters, HEPA filters, face masks, they are fibrous, which means they're made with fibers, and they have, as a typical HEPA filter may have a couple of hundred layers of fibers, and N95 may have 20 layers. So UV, even if you have a good UV, you're going to kill only the whatever you have on the first layer. You will not kill anything inside because the UV gets attenuated by the first layer of fiber. So they don't really work.
Okay. The next question is UV germicidal irradiation an effective tool in cleaning pathogen on the coils or within the airflow?
Yeah, in principle, yes. If you get enough of a dose, high enough dose and close enough to the surface, it will kill the pathogen. And for COVID-19, I don't know what the dose should be. Perhaps one of the other speakers can tell you. But that's the problem, because if you have high enough UV, you're going to generate ozone, which by itself is a health hazard. So my general advice, unless you have an expert in UV trying to design the system, for most of the rest of us, we are probably better off staying away from UV, except to use UV systems. Manufactured, certified UV systems. I believe in China they have, I don't know if somebody has seen these or not, they've got these little high intensity UV lamps mounted on wheels, remote controlled. And once a patient is discharged from a infected room, these guys go in, going around like a vacuum cleaner, robot vacuum cleaner with UV disinfected. There's nobody in the room, so you can freely use high dose. Don't worry about the ozone because there's no person in there. And apparently that's very effective.
Next question that I have for you is, do you recommend in cleaning the return or exhaust ductwork after surgery, after COVID-19 patient treatment?
I don't know. I don't want to speculate. Only thing I've read is there are some data that shows the COVID-19 virus is alive on metallic surfaces for as much as 72 hours. Whether if you have exhaust filters, it probably gets filtered out. Nothing will go out if you have a good HEPA filter. So I don't know. That's a good point, maybe to raise among the experts next time we meet.
The next question that I have is from Akil Clark. Would exhaust fans used to maintain pressure relationships required? I'm guessing this is Akil. That will be to your question on can unfiltered natural ventilation be used in space in quarantine COVID-19 patients in the spaces used?
Yeah, I mean, I think I'll go back here. See, in this scheme, the airflow, depending on where you want the protection, this air can be cleaned or uncleaned, depending on what is it you're looking for. If this outside air, here I'm just showing a vestibule, this outside air, if you think it's clean enough, it's all going in. So you're protected, and whoever is in there is getting all the crap. So it's entirely dependent on the situation.
Vijay, the next question that I have for you is, what is your position on air cleaning devices with solvents, especially in a hot and humid location, air cleaning versus dilution?
I don't quite follow what you mean air cleaning devices versus dilution.
Okay, so so let me just repeat the question. What is your position on air cleaning devices with solvents, especially in hot and humid locations, air cleaning versus dilution?
Air clean, if you put it in principle, they are the same. If you are having, let's say you have an indoor enclosed space, you put a air cleaner, and it cleans the air, a fraction of the air every minute. So it dilutes the rest of it with clean air. So it is actually acting as a diluter, but in an enclosed space by recirculation. Whereas when you're putting air from outside, you're injecting clean air into a dirty room, and then you're diluting it and then sucking it out. From a purely cleaning point of view, they're more or less the same concept. I don't know if I answered the question or not.
Okay. Leighton, probably you can just let me know if the question was answered for you. Next question is, wouldn't a V-style HEPA filter that has more media delivering better airflow are the best of both worlds for more air? Let me just repeat this. Wouldn't a V-style HEPA filter that has more media delivering better airflow the best of both worlds for more air filtration? That
I think
was a
I
more.
think I think that was the, the design reason why these V cells came into play. You get much higher flow without increasing the resistance. But for most hospital type applications, general ventilation, that's probably a good way to go. It still does not work for if you're in a regulated industry for where they're making these vaccines for reasons I don't want to digress here. So V cells are very popular, and you can get it in all kinds of performance levels. And here's a little kicker. If you take a 95% efficient filter, then drop the airflow by 1/5, it will become an alpha filter.
Next question for you, Vijay, is which masks are best suited for general public to prevent coronavirus under the current scenario?
I don't know. I told you, none of the cheap masks will work. If you want to really protect yourself, go get a military mask.
Okay.
But yeah, like I said, it makes you feel good. I mean, I don't want to discount the mask. It makes you feel good. That's a good plus, but you're not wearing it for the protection. If you're sick, yes, wear it. Not just for coronavirus. If you have a cough or cold, any airborne infectious disease, wear it. It will help protect your neighbors, your family, whoever.
Next question that we have for you is how often should local air filters in a room be changed or maintained?
It depends on the air or on the filters and the filter system. And the really high end, if you look at the high end clean rooms or whether you're making drugs or microelectronics, they don't change it for 30, 40 years. You don't need to. Whereas if you're in a house, pre-filters, you change it every 3 months. In the hospital, depends how much use does it get, how polluted is it outside, and how many layers of pre-filters do you have. So approximate rule of thumb is if you have no pre-filtration, if you have a medium quality filter, in the current crisis, I would change it every month. Okay. Otherwise, every 3 months.
Okay. The statement is from Colin Coburn. UVGI is different from HEPA. He wants to know its effectiveness.
I don't know what UVGI is.
Okay. So we'll get Colin to Colin. Can you just send back a full statement instead of the abbreviation? Next question is from Francis. Is it because the F static electricity that the smaller particles are trapped? I'm guessing this is for the HEPA filter question, or for the statement that you would have made during your session. Next question is from Dev. He says, yes, I understand that the random movement of the smaller particle will cause them to impinge on the filter, maybe angular. Any comments on that, Vijay?
I'm not sure I follow that question. I mean, I think I already answered that.
Okay. Next question. Can a portable UV device be an effective means to decontaminate equipment from the COVID-19 virus?
Implanted? What? I missed the first word.
Can a portable UV device be an effective means to decontaminate equipment from the COVID-19 virus?
Yeah, I think we talked about that. If you have enough dose, close enough, and the duration, I don't know what the dosage is needed to eliminate COVID-19. Yes, if not, no. In practice, it's difficult because the intensity you need will put out too much ozone.
The next statement is from Jacob Anderson. He said, thank you for your presentation. Have you seen or performed the CFD, computational fluid dynamic analysis in regard to return grill locations? In recent research, I've seen that the return located in the ceiling, at the ceiling directly above the patient combined with the low wall return, registered to be more effective, more efficient approach to removing contaminants.
Yeah, I think that's what I showed you. If you want the airflow from the one direction and remove the other side, you need to get a sweep of air over the patient. Whether it's coming from the top going to the bottom or coming from one corner and going the other corner on the floor, it does not matter. I've seen some of those CFDs, which I don't know if he's talking about the same ones, that seems to go counter to what we see in practice.
So the last question that I have for you, Vijay, is what specific IAQ advice or guidance should occupiers of commercial buildings consider in reference to COVID-19? And most of the information was focused on hospital settings.
Yeah, I think I started out by saying almost all the things I covered are applicable to any building, especially the airflow. If you look at, if you're getting air from the top, say the one corner of your office, and you want to protect yourself, try to put the return air somewhere else so that you get clean air over you. And don't go the other way. And this is true of a house too. If you have the return air in your kitchen and the inlet air in the bathroom, it's backwards. You're getting all the stuff from the bathroom in your kitchen. So the principles are the same. It's very specific. You don't have, if it's a commercial building, office, or schools, the requirements are less stringent. But the principle of how you define your system is the same.
The last question that I have for you, Vijay, is if you tape a mask to your face and to form a seal, would that make an N95 mask more efficient? I'm guessing that you wouldn't be able to breathe as well, so this wouldn't work. So that's a question from Vikash DL. Maybe you can give some clarity on it.
No, let's take back that will work. If you can get a good seal, it'll work. But the problem is, by the time you get all the good seal around your face, it gets too expensive to use, more cumbersome to use. Little background. For the really 100% sealed face mask, either the full face or the half face mask, they come in 3 or 4 sizes to fit your face. And if you have facial hair, you cannot use them. And what we use in the US or Europe will not work in Japan, Korea, China, because their facial features are different. Their masks will not work here. So it's, in principle, yes. In practice, it's very difficult to seal. Plus, the flip side, once you get it all sealed, your mask itself will not last very long, because suddenly there is no more leak. All the air is going through the material, so they'll get discharged very quickly.
Thank you, Vijay. If there's any more questions, I'd like to just welcome back Dr. Ramroop. Dr. Ramroop, are you there?
Yes, I'm here. Can you hear me?
Yes, I'm hearing you. So I'll bring back in both speakers, and I'll ask the remaining questions to Dr. Ramroop from his session. And if anyone has any further questions for Vijay, please feel free to ask them. Also, we'll add them into the final question and answer session. So one of the questions that was posed to you, Dr. Ramroop, was how about drinking of alcohol? Any effects on the
No, I mean, no, drinking of alcohol might help you relax if it is in small quantities, but it will get you drunk if it is in large quantities. That's all I can say. But it has no effect on it. It has not been shown to kill SARS or MER, so no.
Okay.
70% alcohol is what we use in mortuaries and clinical settings for the stainless steel now, because as you know, it stays very long on stainless steel, relatively speaking. So we're using more alcohol, 70% on those surfaces, and in hospitals, in our clinics and in GPs' offices. That's what we're using a lot more. But that type of alcohol is not what we're talking about, I'm sure.
I don't think so either. Next question is, what is your opinion on medical professionals only having one mask for the entire 12-hour shift?
Bad idea, bad idea.
That is, I mean, you just had a very lengthy discussion on that, and I think that is terrible. And obviously there's a big problem. It is really, really terrible. I'm so sorry, I'm so sad, and I'm so worried about some of my healthcare colleagues in the US, of all countries, where I know a friend of mine works in New York, and he is saying that he has to use his mask, and they're asking them to take the mask and use it back again in the evening or in the afternoon shift, and that's a problem, very much problems.
That's bad news.
Yeah.
Next question for you, Dr. Ramroop, is, in what way is it airborne, or can it be taken into airstreams?
To be an aerosol, you have to be under 5 microns, right? So that anything that is aerosolized and that remains or lingers in air. The studies done by Dormalan and et al. Recently that was published in the New England Journal of Medicine is that they were able to aerosolize it, and it lasted in air. The half-life of the virus, that is the concentration, lasted 1 to 1.2 hours as an aerosol. So that if you're looking at some, for example, like inhalers and nebulizers, where we can bring it to a very fine under 5 microns, if you have an airflow and if it lingers in the air for 1.2 hours in that aerosolized less than 5 microns, remember the virus is only about 0.12 microns. But if it gets in secretions, which might be a little bigger, and it stays in that, maybe you might have a much more viral particles in that little secretion that is less than 5 microns if you aerosolize it. So most aerosolization actually only occurs in medical procedures using fine drills and all this sort of thing. It doesn't happen naturally. The droplets that they use with the cough or the cold, the droplets that are formed by cough and cold is not aerosolized. So you have to understand that, and that doesn't linger in for 1 to 1.2 hours. So that is the difference we're talking about. But if you're in a orthopedic theater and you're using drills, or if you're using fine instruments like an ENT, or you're drilling bone, you're going to produce these little aerosols that could actually linger in the air. Did that answer your question?
I'm hoping that it did answer the question.
Yeah.
So
remember, you have to be careful about the definitions of airborne and aerosols. See, a lot of people thinking that if something is airborne, what it means, right? The virus itself is just about 0.12 microns, right? But remember that the fluid that is coming out of your oropharyngeal surfaces, right? When you sort of push that out through your nose and mouth, right? Those are larger droplets, so larger particles. It wouldn't be aerosolized. It wouldn't be aerosol. The researchers, Dormalan et al. Recently, what they did is they made the virus into a sort of, they mixed it in the form of and they formed an aerosol. And aerosols tend to be less than 5 microns. We're not sure about the details of how they were able to do that. And when they did that, it lingered in the air. The half-life was about 1 to 1.2 hours. That's the only research that we have seen recently with respect to the COVID-19.
If you generally look at a 10 micron particle,
yeah,
it settles out about 1 foot a minute.
Right.
Whereas if you look at that 0.1 micron, it settles out like 1/10 of a millimeter per minute.
Right.
And even if you have the slightest amount of updraft, it's going to be airborne forever.
So the danger there is mostly in highly, in procedures that involve operating on a person with an infection. It is not something that will occur naturally if the person coughs.
The next question I have for you, Dr. Ramroop, is I've read that viruses can be killed by prolonged exposure to sunlight. Can a UV light be used to kill the virus?
The answer to that is no. There's no research that shows that. The study done recently, I just quoted, they use different temperatures, but none of the coronaviruses have been shown to be killed by direct UVA type sunlight. If you go into UVB, of course, that has a little more potential to do. They do affect it, but in terms of the amount that you're going to be using, and as you know, in China, they're using the UVC, and they're using it in buses and all of these things overnight to sort of kill the virus, because that is potentially carcinogenic. So really and truly, the answer to that, no study has come out to show the effect of sunlight, direct sunlight on this COVID-19, but research done on the coronaviruses is that they didn't affect them much.
Next question we have for you is, can the virus be spread in takeout or restaurant food?
Well, those are fomites, and if somebody who has the virus, and I mean, I don't expect people like that to be working now, but we are seeing studies, we are seeing evidence where persons who do not actually exhibit symptoms. I mean, this is coming out of the literature, and they are shedding the virus just before those symptoms come. So if, for example, a person like that takes your box and puts it in a plastic bag, remember, it stays a little long on plastics. We just saw that, up to 3 to 4 hours, 72 hours, right? The plastic bag that they're giving you, they can transfer the infection from their hand onto the bag onto you, right? If it's just a box they're giving you, it stays a little less on cardboard, but it's still ours. It's still ours. So which means that it could be transmitted to you. That's why they were worried about, Amazon boxes coming down to you in less than 3 to 4 hours in terms of cardboard. So yes, I mean, that study has shown that it stays on cardboard within 3 to 4 hours. So yes, the answer is yes, clearly.
Okay. The question is also an additional question to the previous question. How about delivery food? Can the virus also be in food? So yes.
Well, I mean, the answer to that is if there's direct, secretions that fall onto your food, or, I mean, most of the times, it depends on how food is. If food is prepared and it's cooked, etc., and then served, of course, you're not going to get it, because the heat and the microwave or whatever things should be enough to get rid of it. But obviously, it's what happens after you prepare the food, when you package it and deliver it and put it on your plates, and how you touch your plate with your hand, and there's so much.
Okay. The next question for you, Dr. Ramroop, is will it be killed or damaged by a UVC light?
Well, we just said yes. The answer to that was yes. Chinese are using it, but UVC light cannot be used practically. I mean, in terms of putting it, the equipment is very expensive, setting it up in your operating theaters and whatever. As I said, the Chinese seem to be using it, for example, in buses and areas overnight. And it does show, because it basically damages the genetic makeup of any living organism. But the point about it is it's dangerous. It cannot be used practically on human beings, because it will cause cancer. It'll burn. In fact, it irritates the eye, the same grittiness that you get with your eye, if you look at direct sunlight, and that's just mostly UVA. When you look at UVC, that happens to you almost immediately. It's very dangerous, very, very dangerous.
Okay. Next question for you, Dr. Ramroop, is there any research on any amount of time the secretion remains at respiratory system level, 5 or 6 feet elevations, and what recommendations are there on either decreasing that time or pushing the particulates down?
The answer to that is no. The only research we have done, we have seen recently, we have not seen any research on, for example, high altitudes, in high pressure, and like, for example, pressurized cabins in airplanes or whatever. And those are things that will happen. I'm sure I'm sure there are people out there who are looking at the different types of circumstances in which virus will survive, because that is needed right now. I mean, I think recently I saw some article came out that it survived for days in some of the cruise ships, on surfaces. So again, there are some outliers to this virus. But no, the answer to that is I have not seen any peer-reviewed evidence-based, any sort of study that is actually looking at the effect of pressure, high pressure on the viruses, or altitude, or even high temperatures. Recently, again, the New England Journal of Medicine, they did say they used some of the different parameters, but I myself haven't seen the details of that in terms of, how long did they use a high temperature, what was the temperature they used, and all sorts of things. Those studies, like all scientific studies and analysis, will have to be duplicated, will have to be reproduced, and it will have to be peer reviewed.
Okay. Next question for you, Dr. Ramroop, is how long is it expected that the virus will last in this region?
I think that looking at how it is going to be a global. We have to look at the global trend. Summer is coming in the temperate countries. It seems that a lot of people are hoping that when the sun comes, they're going to get some reprieve. I am not sure, but from all the evidence, it seems that we're going to be looking at maybe up to about May, June. You will still have remnants of that virus around. And that is my sort of just understanding based on the literature that I'm reading, not on any experience. I'm sorry.
Okay, no problem. And the last question for you, Dr. Ramroop, from your segment is, are there any particular procedures that must be taken for a hospital after a procedure or a surgery has undergone with a COVID-19 patient?
Yes, I mean, we have to operate on everyone. Somebody has an appendicitis and they're currently in quarantine and they have COVID-19, we have to operate on them. So yes, we have to operate on them. But again, it's not a problem. I mean, we have always been in all of our hospitals all over the world adhering to very strict protocols with respect to highly infectious or highly infected patients. So I don't see that as a problem. I mean, the use of proper ventilated, for example, in orthopedic surgery, when we're doing hip surgery, our ventilation system is definitely different to if we're using it in any other type of surgery. We also have to look at how we're looking at generating our aerosol sprays when we're doing drillings or as we talk, if we're going to be cutting bone and generating sprays. So again, it's all about proper procedural. It's standard operating training of all persons like us who are trained in surgery, the nurses, the people who are going to be cleaning the operating theater after. It's very simple. If that fluid gets into you, especially if it gets into your oropharyngeal space and goes into your lung, you're going to get the disease, right? We have not seen studies where the viral load is an effect. In fact, what I'm trying to say is that if two little pieces of the virus under 3-4 microns or get into your system, how is that different if you get about 25 to 80 particles? So there's no study that looks at the concentration. Clearly, if you have high concentrations, you'll have more effects on the immune system. So the answer to that, proper protocols. We have been doing it for years all over the world in terms of operating theaters. We have been operating on HIV patients. We have been operating, and in fact, we did operations on Ebola patients in some cases. So yes, there are data to show that we operate on infectious patients. Follow infectious protocols and minimize the risk, and make sure your theater is operating, your cleaning people knows what they are doing, your air filters are changed regularly, you're doing swabbing of your operating theater before and after. So it's just what we do.
Okay. This question is for both you, Dr. Ramroop, and Dr. Vijayakumar. Why is the Italy outbreak seems to be so much worse than other places?
Well, I would like to, Vijay, if you want to go first, it's no problem.
No, I was going to say, you're the doctor, you can tell me.
But the reason for that is if you look at the demographics of their population, they have an older population. If you look at their age in terms of longevity, their healthcare system is much better than a lot of the European countries. I mean, Scandinavian countries, they do have better healthcare. But because of their good healthcare system, people are, and the social system especially, not so much the healthcare, is they live longer. You go to Europe and you walk down some of the villages and the streets, you see people who are 85, 95 years old walking down the street. You don't see that so much in the Caribbean. When people reach 60, I mean, I'm an orthopedic surgeon, and today I have a lady at 65, and she broke her hip, and she looked like an 85-year-old. So a lot of that has to do with the state of health, state of nutrition, the standard of healthcare, the social system, and I think it's much better than most, and that is why they're living longer. Now this virus has a predilection for the older person, so that is why you're getting a larger number of deaths, because they have a higher population. And I also think that they allowed the virus to kind of get into the community a little longer. It took a little longer time in getting the act together, and that could have resulted in just 1 day of contacts. I mean, in a society, would cause quite thousands of contacts, and that is also a problem.
The next question that I have for both of you all is: has the use of copper fixtures, such as door handles, been shown to have an effective method on reducing the spread of viruses in hospitals?
I have no evidence. I've not seen any.
Yeah, we have not seen it. We know that the research done by the guys recently and as published said that copper, it lasts very a lesser time than others with copper handles. But to be quite honest with you, I have never seen anything put into that in the healthcare setting.
I think one thing we all should be cautious is there's a lot of, like Dr. Ramroop was saying, unverified anecdotal data. So we cannot make decisions, life and death, based on those.
Yes.
Next question that we have for you guys is: how do risk assessment and respiratory protection programs fit into the arrangements in a hospital setting? How are these areas being reevaluated given the pandemic risks with which medical professionals now are faced?
Kiran, I thought, don't we have one of the panelists, the future ones? I thought he was a risk assessment expert.
Yes.
So
I'd
defer to him.
You can give a brief answer. We'll go into it. Michael will go into it. I could pose this question to Michael at his next week.
I mean, what I'd give you would be anecdotal, and I don't want to do that.
Natasha, that question can be Dr. Ramroop, if you give from a medical perspective.
My experience from a management perspective, in terms of as a medical chief of staff at the San Fernando Hospital, which was a 775-bed hospital, we have an infection control department, and we have experts in infection control. One of my consultants was very, very experienced in that. And when I was the chief of staff, what we had was we set up a dashboard, a scorecard. And what we did is we used metrics to monitor the infection status of the hospital in terms of doing audits of things like hand washing, the number of persons who use the devices that we put out. We had to change over all the taps of the wards, for example. When I was there, when we discovered that some of those taps were, was like what you have at home, where you turn the handles and you didn't have the elbow type, and that decreased the infection rate. The answer to that is it all depends on management of the hospital setting. In our country, I can tell you for sure that there has been no healthcare management policy with respect to monitoring risk as it when you look at infection control, and because of that standard, there's no standard in all our regional health authorities, and even in the public health setting, that is a universal standard with monitoring and evaluation of what is happening in the health sector. So we have a very poor healthcare management system in Trinidad, and we have actually been very lucky to kind of come out with some of the big problems that we have in hospitals, like nosocomial infections due to Pseudomonas or E. coli or Salmonella outbreaks, etc. We had, when I was medical chief of staff, we had a cluster of infections in the dialysis unit, and it turned out that it was really a hygiene problem because of the staff, and these people were obviously reduced immunity. And the biggest problem we found there when we did the audit was that the method, and some of the staff was not hand washing. And doctor, we agree that one of the biggest, the persons who were the biggest culprits in that were doctors. And that was one of the things. We even looked at the type of clothes we wear. In our country, we don't normally wear surgical gowns or scrubs in our hospitals. in most of our hospitals, and that has been a big problem because we worry about infection coming from the clothes. So there's none. We haven't done much clinical audits and infection control monitoring in a risk-based. It hasn't been a risk-based approach, and that is the reality of it now.
I have the last two questions for both of you all. Let me ask both of them. In what temperature range does the virus survive? And also, how does it react? Radioactivity affect the virus?
I leave that to doctor.
Well, yeah, as I said, we have no sort of verified study on temperature. The group that just did that recent research that was published in the New England Journal did use temperature, but they didn't really mention of the effect of temperature on the viral concentration or the half-life of the virus after a period of time. They concentrated on the surfaces, but they used different parameters to look at the half-life. Again, I have not seen the detail of the temperature and the viral half-life as it pertains to the temperature variations. There's none. We just have to wait and see what happens. Clearly, radiation is used in healthcare settings to sterilize many pieces of equipment that we don't want to put in solutions, right? For example, and therefore we use it in our endoscopes and quite a lot of equipment that actually cannot be water or saline cannot be used on. And yes, it does kill almost everything that comes under its on the rays, depending on, of course, which type of radiation is used.
So, Dr. Ramroop and Dr. Vijayakumar, the ASHRAE Caricom chapter, once again has to thank you guys for taking the time to impart your knowledge on us. It was quite an informative session. Do you all have any closing words for the attendees?
Like I said, my only closing word: don't make decisions, life and death, based on anecdotal information. And I really enjoyed the questions because we learned a lot too.
Same. I have not much to add. Again, now is the time that we're going to be seeing a lot of people writing a lot of stuff. Most of you all who would have done your postgraduate work or graduate work will realize that you have to be very careful in how you cite research and how far they go back, and you have to look at both sides of the picture. So again, I want to endorse what my colleague is saying with respect to information and how we take that information and transfer it into knowledge. Right now, we are all learning a lot about this virus, but when it comes to practicality, what my message is today is about what is how do we deal with it. No matter what we face in this world, we have to find out at the end what is the final, how does it affect us? What is the final outcome, and how does it get to us? It gets to us through our nose and mouth, and it infects us and it kills us when it causes reactions in our lungs, particularly when we are old and when we have a reduced immune system. To prevent it, we have to make sure that it doesn't get there. And therefore, we have to use very simple things, hygiene, and of course, how we wash our hands and protect that virus from getting in. That's all I have to say at this point in time.
Okay. Thank you, Dr. Ramroop. Thank you again, Dr. Vijayakumar. Just a reminder that the webinar will be continued next week, Thursday at 6:30 p.m. We start off, and the first presentation will be at 6:45. We'll have the Lawrence. Hold on a second. Let me just confirm. We'll have Michael Shurin doing his presentation on healthcare, ventilation in healthcare facilities, and we will also have Lawrence J. Schoen, who is also going to be presenting on ASHRAE's position on airborne infectious diseases. So if you guys enjoyed today's presentation, next week's presentation is going to be even better. So we just build on it. Once again, thanks guys. Just don't forget to register for it and share with your colleagues if you enjoyed today's session. The link will be sent out in due timing for the recording to share with your colleagues, and I will share Dr. Ramroop's and Dr. Vijay's contact information with you guys, or you can reach out to them on LinkedIn and or via email once the information is out. So once again, have a good evening. We have to say stay at home and ensure to wash your hands. We look forward to your feedback via our email at ashraecaricom@gmail.com, and we look forward to seeing you all on next week Tuesday. So thanks once again, and thanks Dr. Ramroop, and thanks Dr. Vijayakumar. Take care.
Thank you.
Good night,
Okay.
everybody.
Good night.
Good night.